For being here. Public safety pushed us here about 10 minutes late, but that's quite all right. The transition was pretty smooth, and we're happy about that. I don't know exactly how we're going to solve that, because me walking in the back of the room and doing all that. So the chairman will have a discussion relating to that. Chairman Sessler, do you mind opening us up in our prayer today? You're mic number 5.
Thank you. Happy to. Let's pray. Dear Heavenly Father, we thank you for all that you've given us, for all the blessings you've given us. We just thank you for those that are gathered today. Thank you for the call to civil government, that everybody in this room is part of in an important way. Bless our dealings, bless our deliberations. I pray that you'd be glorified in all that we do. We pray this in your holy name. Amen.
As the session goes along, the pace picks up, and so we have 2 bills today. We're probably going to have a couple bills. We'll put out the schedule either later today or first thing in the morning, but we'll have at least a couple bills on Wednesday. So this is our short session. So from 2 to 3, we're here. We have this sort of a drop dead at 3 or maybe 2:55. It would be courteous to the people who are in the room after us. And then on Wednesday is the one that we can go a little bit longer if we need to. With that, Chairman's prerogative and logistics calls for us to go with Senate Bill 101 first. The substitute that we had was agreed upon. The Chair of Rules had talked to me about it, so we accepted his substitute, but we're just got the changes and new analysis. So that is in your folders, the new analysis. Not much change there, but we're going to give you a chance to digest that a little bit. So we're going with Senate Bill 101. The majority whip has the bill, and I have not looked at the sign-up sheet, but we're here. I see we have 3 people signed up, and we're going to hear testimony today, and I'm going to decide whether this is going to be hearing or vote. I'm leaning towards a hearing today, and the history. If you'll give us the history, what happened last year, maybe this year, I want you to take the podium there, and Senator Robertson, the floor is yours.
Thank you, Mr. Chairman. Mr. Chairman, briefly, on as far as the history goes, as much as I'm aware, there was a decision to lean into the federal government and wait for them to make a decision related to this. And all they do is make a recommendation. They don't actually police how we handle this. But Senate Bill 101, and we hear this all the time, it's a very simple bill. But I want to tell you, it's an extremely, extremely important piece of legislation. Because what it does is, if you look on line 14, it talks about the department shall promulgate rules and regulations creating a newborn screening system which shall include screening for Duchenne's muscular dystrophy. With the exception of a couple on the committee, I doubt many are familiar with Duchenne's muscular dystrophy. But to let you know, it is 100% fatal. When my daughter, who many of you know was born 5 years ago, when she was 3 days old, we knew that she had GA1. We knew that we had to use a particular type of formula. We knew that if our daughter got a fever and we were not able to get it down in a fairly quick time, that she suffered a real risk of brain damage because of her body's inability to process proteins. We found this out when she was 3 days old. That's the importance of the heel prick and the procedures that are done here in the state of Georgia when newborns are had. What we find out with Duchenne's muscular dystrophy is parents don't have that. They don't have the ability to know at 2 or 3 days out that their child is inflicted with this type of muscular dystrophy. And so what they do over the next 3 to 4 to 5 years is they spend many times tens and hundreds of thousands of dollars taking their children to physicians trying to determine what exactly is happening with their child. And then by the time they find out and they're told This is the problem. There's genetic testing, there's other things going on, but there's nothing you can really do right now to address the problem you have. And we do have a father here who has two sons that have this type of muscular dystrophy, and I've met with he and his wife. If you pull out of my driveway, they live less than 1 mile from where I live. And when you see these two young men, these two boys, they look great, but it tears at your heart knowing that their mother and father, who love them dearly, put in all the effort in here to see these kids. And I want to tell you, there's a cost associated with it. And the cost is $8 to add this. And you say, well, Randy, $8 is for one child, so what are we looking at overall, statewide? Because we have the equipment. All we have to do is do the test. And right now, the false positives on the test are 0.08. And I could be leaving a zero out. It may be 0.008 right now. But the false positives are extremely rare. We have the equipment. All we need is the permission. And to do that, it would be a capital investment of $752,454. And I'm going to say that thing that we all say because we think it's going to push somebody to the edge or make somebody make the right decision. But I know I'm standing in a room, including this crowd here, of mothers and fathers and grandparents. And I'm going to tell you, I've got 3 children, and they're worth a heck of a lot more than $700,000. And I can't imagine Andy, my daughter, me not knowing her condition until she's 5 years old. Me not being able to not only seek out every medical solution possible, but also missing out on the opportunity to make her life as perfect as I possibly can, especially knowing that at this time and place, and look, there's research going on each and every day, and that's something we have to support and continue to support when it comes to health care. But knowing that we're not there yet, I want my daughter to have the best quality of life possible. So when the inevitable comes, I know I did everything as a father to take care of her. And the families that have children that have to deal with this type of muscular dystrophy deserve the exact same opportunity that Randy Robertson has. And I think by looking at this practically, at the cost, by looking at how simple it is, they take blood out of the hill of the child, it's sent in and it's tested with every other thing on the panel, and the family, the mother and the father, the hospital get a result back normally within 3 to 4 days. We took Andy from the hospital. We got home 2 days later. They called us from the hospital and said, hey, bring her back. There's something we need to talk to you about. Teresa and I carried her in. There was counseling. They told us what the issues were. A week later, we were up at Emory. We were getting a protocol. We were getting all of the support we needed from geneticists and everyone else. And I'm going to tell you, this family didn't seek me out because I have a daughter who has this issue, an issue similar, just not fatal, if we follow protocol. I just happen to be their state senator, and I just happen to be somebody that realizes this is serious and we need to address it. We need to do everything we can to protect families here in Georgia, and this is a big part of it. And Mr. Chairman, I appreciate your time, and I do want to point out that I've spoken to individuals from Dr. Kathleen Toomey's office. They are a little concerned that this kind of goes out of the normal protocol, but the reason it goes out of the normal protocol is there have been diseases that have made it onto the panel that aren't 100% fatal. We have this one that is, and this is not the time for more pilot programs that sunset and drop off. We know what the problem is. We know what the solution is. The biggest thing standing in the way of these two children right now is bureaucracy. And the people that can remove that bureaucracy and increase the quality of life, not only for the two little boys you're going to hear about today, but for every child born in Georgia who has this type of muscular dystrophy, is for this committee to vote this bill out. And with that, Mr. Chairman, I'll stand for any questions.
So what I'd like to do is I'd like to hear from department first, and then hear from patients and pediatric neurologists. So, and then we'll come with questions and let you finish up. So, Megan Andrews, Georgia Department of DPH, thank you.
Hey everyone, thanks for the time today. My name is Megan Andrews. I'm the Assistant Commissioner for Policy at the Georgia Department of Public Health. Thank you guys for being here to hear about this very important issue. And I think me and Senator Robertson agree on the fact that this is very important, and we do agree that it is important for families to know what is going on with their child. I do want to provide some background to you all as the committee on how this process typically works, so you're in the loop and can decide the best path forward. So generally, the conditions are reviewed by a group of physicians, medical experts, geneticists that take a look at a lot of research and data. Is there treatment? And there should be our regulations in your packet. It's a Westlaw printout with subsection 511 from our regs. It has a list of what that committee looks at when they are reviewing conditions. So they look at things like whether the disorder has significant morbidity and mortality when not identified and treated before symptoms, if a clinical identification of the condition is likely, the prevalence of the disorder, the use of effective technology, and the need to perform additional tests. A lot of these conditions, they'll pop positive on the first tier screening, and then they go to a second tier screening, and in some cases a third. We also look at whether there's resources for follow-up and counseling available. That's important because when you test someone, you need to have a place to send them to go get care. And that was a challenge. If anyone remembers Krabbe disease from several years ago, Senator Burke was pushing the addition of that condition. And that was one of the challenges, was there was nowhere to refer patients when they tested positive for case management and all of that. We got to the point now where that is added to the panel. It's actually in your budget that came over to the Senate this week to add it as a permanent condition to the panel. So this committee is made up of clinical experts that look at all of these factors to decide whether a condition should be added to the panel or not. The feds also have their own process and their panel that reviews it too. We established a state process so we can add conditions that the feds don't recommend because it's true. They do sometimes take a very long time to do things. So we have a state-run process, and that is how Krabbe was added several years ago. Krabbe disease, it is not recommended by the feds, but Georgia instituted it. It went through this committee process. They recommended it be piloted for 3 years. The legislature graciously funded that, and that pilot just ended this past September. And there's funding is continuing, and it's becoming a permanent condition on the panel. That pilot period gives the state time to collect data and set up those referral mechanisms and places to send these families when they get those positive tests, which is why we think a pilot is important. This work group has been meeting on this condition since the spring of last year and gathering data. Even the advocates had data coming out over the summer for the feds to review. So our committee is doing its own data review, not relying on the feds. And they are we are expecting at their next meeting them to recommend that the state pilot this as a new condition. It would likely mirror what the Crab A pilot looked like, which means every baby is tested, every baby is screened. It's not piloted where like a geographic region or 1 in 8 are screened. Every baby would be screened in a pilot setting. It would just be set for a certain time period so the state could gather data and look at the effectiveness of that pilot program to see should it be added to the permanent panel or not. So that's the current process where we're at now. I wanted to share that so you guys had the background. Right now, conditions are not added through statute. Certainly you're free to do as you please, and if you would like to add it to statute, then we're mandated to follow it. But right now, the statutory process that is set up is that it's supposed to go through this committee and they review and make recommendations to the commissioner. I'll leave it at that, and I'm available for questions if there are any. I'm not opposed to the condition. DPH is not opposed to adding the condition. We are more so concerned with ensuring the process is followed where there's a clinical perspective and eyes on it before it's added to the panel.
Questions, Senator Cowser?
Thank you, Mr. Chairman. I don't know if I fully understand this program. Is it mandatory for infants in Georgia? Is this a government-imposed requirement, or is it something that's optional and available to parents for their children?
Every baby is given a screening, but parents have the option to opt out if they would like.
And this equipment we're talking about, if I can, is that something that the state owns? Do we already have this testing equipment?
Yes, so we have a state lab that's over in Decatur off of Claremont there, and we do all the newborn screening. So at Heel Prick, we screen for over 30 conditions, which is listed also in your packet. I need to get with the lab to see, because when we've added conditions in the past, we have had to do renovations to add new pieces of equipment. I don't know at this point if the equipment we already have on site is capable of running the test for this specific condition or not, so I can get back to you on that. But we do have newborn screening testing equipment. All of our tests are done in-house right now for those 30 plus conditions. When we get to the second tier, they are sometimes sent out to Mayo Clinic or other clinics to do that higher level of testing.
One final follow-up.
Sure, when you say second tier, you mean as in like something's positive and then you want to verify it or define it a little bit better?
Yes. So, for example, my son tested his newborn screening positive for cystic fibrosis. They ran a second tier test actually in-house at the lab, and it still tested positive using DNA, and then it was sent to Mayo Clinic for third tier testing. So there's a lot of levels of tests that can and do go on. It varies depending on the condition and our capacity at the lab.
My final question is, why do we need legislation for this? I mean, why don't parents just test their kids for what they want to and pay for what they want? Is it something that is mandated on parents to do, and or is it something that must be legislated before insurance companies will reimburse for the cost? I'm not seeing why government has to get involved.
I don't know the history of why if like insurance was refusing to reimburse it. It's a general program that all states have, is to screen newborns for inheritable diseases to try and catch them early. At one point in time in the history of this Crab A, that's my most recent example, there was a portion of time where there was information provided to the parents in the hospital, and then they could do the screening themselves through a private lab. This just eases that burden on parents to catch these things early. And again, if they don't want their child to be tested, they can opt out. But in the hospital setting, there's a lot going on for the mom and the dad and the baby, health-wise for the parents. This is a way that to catch things early in order to have the best course of treatment for that child, to make sure, because a lot of these conditions, if they are caught early, they can have really great outcomes as long as they are following the right course of treatment. You know, Senator Robertson had a great example with his own child. So
Yeah, this is from my medical school just a couple years ago. So I think initially, when I came in the legislature, there were probably half this on the list, and it has grown. But the classic ones were if I remember, it's even listed as classic phenylketonuria, PKU for short. You'll see, and that's one of those that if you don't catch and adjust the diet, they'll be significantly or profoundly affected neurologically, and will not be functional. And so that's one of those that if you don't get within the first few days or so, and they'll be profoundly affected. So I think that was the logic years ago. So any other questions from the committee?
Thank you, Mr. Chairman. And to the chair, is someone going to speak kind of on the opposite side of this question that she expressed concerns?
We have two more to. We have two more to. One's pediatric neurologist, and one is a father. If I think that's accurate.
I just asked because I want to hear. I mean, to understand the bill, I'm used to sort of hearing both sides of things.
Yeah.
Would there be drawbacks that you could express, or should I wait for someone else to talk to that?
I think we can get
Drawbacks to testing?
To doing this? Yes.
Oh, to doing this bill. I mean, our concern is it's going around the process that's established in place already where there is a clinical review, right? Because if you're going to legislate it, you're skipping that whole step where doctors are reviewing it and seeing if it should be added to the panel or not. Is there treatment options? Are there places to send these babies to get care? That's our concern.
Okay. Anything
It's
else?
not about the testing. It's
Two.
Yeah, two, I'm sorry. Yes, sir. Thank you, Mr. Chairman. Yeah, we used to have a process similar, it was called GORC, and we eliminated that, so.
I
just-
remember I was on that committee.
Anyway, I've got a question on the crab A. You say we do it here in Georgia, but it's not federally mandated, right?
Yes.
So how many of kids end up with crab A? I don't even know what crab A is.
Well, the doctors can probably talk a little bit more about it, but during the pilot period, we identified one child, which
Okay.
was a 3-year pilot.
It was a 3-year, okay, so you identified one.
Mm-hmm.
And then how many, I didn't catch how many, do we know how many kids have the Duchenne muscular dystrophy
Well, we don't
roughly?
know, right? Because it's not part of the panel, so we're not getting regular tests, and typically they're diagnosed older, like 4 or 5, is my understanding. But the neurologist can probably talk a little bit more about
Okay.
prevalence.
That's all, Mr. Chairman. Thank you.
All righty. Thank you, Ms. Andrews. So we'll have, I'm sorry, I didn't see that. Goodness gracious. Here we go. What number are you, Senator? 12? Okay. We
Thank you.
do have another bill, so let's try to be
Great, thank you, Mr. Chair.
judicious here.
The cost, the number that the senator provided to
Yeah.
us, what is that cost covering, and is it annually or?
Yeah, it's an
one
annual.
time?
It's an annual cost, and I have a budget. It actually should be in your folder. I dropped it off with your admin earlier, but it's for a staff person to oversee the testing at our lab. We have to purchase reagents, which is part of the testing process. Equipment. We also refer all of these cases, as he mentioned.
It is in the budget. There's, and
You
I
got
think,
it? Okay.
Yeah, I see it, uh-huh.
Perfect.
I
Okay.
see it, so there's the follow-up, it seems that this is about catching up with the science. That it's been established, and also that there are now there are 2 meds that treat this, which allow the parents some options. But typically, if you're not tested, it may be 5 years before the condition is diagnosed. And all those years that have gone by, you've missed opportunities to address the needs, the health needs of the child. And so there really is an argument, in my opinion, for let's cut to the chase and get this done. I know about 5 or 6 other states are looking at doing that. And I would just want to raise one more point. Isn't it true? I mean, this is a genetic, inherited disease condition. And so people planning families do not want to have 3 children before their first one reaches 5 or 6 and get the diagnosis. They don't, the earlier the parents know that this is a genetic anomaly that they're dealing with, then that gives them a whole different perspective on the size of their family and whether they're going to adopt, whether they're going to, just how they're going to manage all of this. So I think there's several points here that do argue for an expedited approach as opposed to the long, patient.
Thank you, Senator. All right. Senator Harrell?
So my question surrounds what that process is like. I know I had a Girl Scout come to me during the interim who had Gaucher disease, and she was, as part of her Gold Award, she was going through the entire process through DPH of going through the hearings and everything. I don't even know what has happened with that, but to me it's a question, of course this is a good thing to do, but do we do it here legislatively, or do we do it through the process where doctors get to look at these and the department gets to consider these 7 questions? So how long does that process, like what my Girl Scout went through,
Right.
how long does that take, and how many things after going through that process don't get approved?
I actually have our child health director here, Kimberly Ross, can come up and talk about that because she manages the committee to talk about how long that process is. I will say this one, it's been about a year at this point, and they are preparing to vote on a decision. So that's at least a timeline for this condition, but are there any others that you could?
Sure. It really can vary because once a working group is established, it could be the next meeting. So the Newborn Screening Advisory Committee meets in April and October. They can meet in between if the chairs call them. So it could be, if there's enough of the research there for the condition that the group sees and they can answer all of those questions, they can come back at that next meeting and recommend that it be something that be considered to add to the panel. And then there is a legislatively written process for after that. So there's a recommendation to our commissioner, and then the commissioner would then, there's a budget attached to that too, so then she has to have the budget piece appropriated, and then there's no more than 18 months that the lab can build out the process, that we contract with Emory to do follow-up, so they have to do the process for follow-up, but that all has to be in place. It's usually within a year for that all to happen.
Thank you.
Thank you.
Sure.
We appreciate that. Let me get Dr. Farr to come up first, then we'll have the patient advocate after that. Dr. Farr, tell us about yourself, and the floor is yours.
Yes, hi, thank you for allowing me the opportunity to speak today. This is very near and dear to my heart. My name is Han Fan. I'm a pediatric neurologist. I got my training at University of Alabama in Birmingham in the early 2000s, and over the last 20 years or so, I've been seeing a lot of Duchenne's patients, both here and in Alabama as well. Duchenne's community have grown and have substantially. There's an increase in awareness of this condition. It is true that newborn screenings are for those conditions that impact patients in the infantile period. This is, of course, the average age of diagnosis at 4 years of age. But by that time, family planning, early interventions, early treatments, there are now roughly, I believe the last time I count, 5 approved therapy for Duchenne muscular dystrophy. So if we are not able to catch them this early on, it limits our ability to intervene and treat appropriately. In the state of Georgia, the birth rate is roughly 125,000 per year. It could be more than that at this point. For Duchenne muscular dystrophy, the prevalence is roughly 1 out of 3,500 birth rate, which means that if we were to implement this for the state of Georgia, we would catch roughly 35 patients or 35 newborns that we can implement treatment early on. We now have gene therapy that's been approved. We have other therapy that's been approved. And I can see over the last 20 years that this condition typically results in death in their late teens. But now we have patients living in their 20s and 30s because of standard of care improvement, because of early interventions and treatments. So I think that implementing this may be very helpful in early diagnosis and early treatment and early intervention and for family planning as well.
So are you doing the treatment now with genetic treatment now?
Yeah, the Children's Hospital and Emory clinics are implementing the treatments now.
And what age does that start?
It starts as soon as you can diagnose them.
And the prognosis relating to that?
Depending on the treatment, there is a gene therapy that can improve the treatment and prolong the lifespan. There are some treatment that can slow down the progression. Typically in Duchenne's, their average age of loss of ambulation is roughly 12 years of age. So with this treatment, you can prolong. And I've seen patients who are in their late teens and still walking. And that's very meaningful for these patient and family.
Sure.
These various types of treatment, what's the cost of those?
It
The
depends.
gene therapy?
So the gene therapy currently, I don't know in terms of insurance, but roughly I think $2 million.
You said $2 million per treatment
For the gene therapy,
over a lifetime or over a lifetime?
right?
Any other questions at all?
I had one.
Senator Art?
Could you tell us, you said with the numbers of births in Georgia and the average, there would be roughly 35 children whose condition would be uncovered by this newborn screening. How does that compare to numbers for some of the other conditions that are screened for? You may not know the answer to that question.
So I think for Krabbe, it's much less. And so
Fewer children.
Fewer
Fewer
children.
infants.
For that reason, we only, as mentioned earlier, identify one patient, one newborn. For spinal muscular atrophy, is 1 out of 10,000. For PKU, I think it's a little bit less.
A little bit less than 10,000, or,
Right. So
thank you.
Any other questions from the committee? Thank you, Dr. Farr. Appreciate that.
thank you.
All right, Ryan Salmon. Appreciate that. Floor is yours.
Yeah, I appreciate your time today. I'm coming today as a father. I have 2 of those 35 a year. Well, I have 2 sons with Duchenne muscular dystrophy. So that's 2 kids, at least one that could have been identified at birth and received treatment earlier if this was already implemented. I have a bunch of notes here, but I decided, I think, with what's been said so far, I think I'll just tell our story real quick. My son Jacob is currently 12 years old, about to be 13. And when he was born, we saw as a baby that he was delayed, slow to walk, slow to roll over, slow to stand up. And we were told by the pediatrician, don't worry, he'll catch up. About 3 years old, he started complaining about leg pain. And, Daddy, my legs hurt. I can't keep up with my friends. So we took him back to the pediatrician, and we saw another doctor, and they said, hey, let's just put some insoles in his shoes, and he'll be okay. At 5 years old, Jacob was playing soccer, which he never should have been playing, and we would have known that if he was screened at birth. After playing soccer, we went to eat as a family, and I don't want to get too graphic, but he had to go to the bathroom, okay? And he said, Daddy, I got to go to the bathroom. And I said, okay, I'll take you. And when he went to urinate, the color of his urine was the color of Coca-Cola coming out of a can. And he had severe muscle breakdown from all the activity that he should not have been doing. So we took him to the emergency room in Columbus. I live just outside of Columbus, Georgia. And luckily, there was a good pediatric doctor on call there who said, hey, there's something seriously wrong with him. We need to get him to Atlanta today. And we were in the ambulance not long after that with Jacob hooked up on IVs, heading to up here to Atlanta to CHOA. Jacob spent 3 days in the hospital. We were waiting on neurology to get to us. And by the time we saw the neurologist after 3 days and being poked and prodded, we were told, hey, look, it looks like he could have this devastating disease known as Duchenne muscular dystrophy. And we had no idea about any of that. And I'm sure many of you probably remember watching like the MDA telethons and all that on television growing up. And when I was told that, hey, he's got this muscular dystrophy, I thought, oh, okay, well, there's got to be a cure now, right? There's got to be treatments, because they've been talking about this for years. And we came to find out that there really wasn't anything. And that was only about 12 years ago. Or, I'm sorry, he was 5 at the time. When he was diagnosed, we learned that there was an exon skipping treatment available, and that he could go for treatment at 5. Now, what that also led us to is my younger son was 1 year old at the time. So now we're getting closer to newborn screening, where we can start planning a future of a child that is 1 year old and looking at treatments and figuring out where we can take him instead of scrambling, trying to find care at 5, 6 years old for a child. Because we were able to screen Hudson, my youngest son, early, he was able to get into a gene therapy trial. And originally it would have been 2 years old because of politics and all that, having to go through FDA and everything. It got delayed till 4, but he was still able to get treated at 4 years old with gene therapy. And he's 8 years old today. My older son, Jacob, is, like I said, he's 13. He does exon skipping. He actually does it with Dr. Fan here. And at 13 years old, because he has had the correct treatments, he's able to climb out of my truck and walk into school with his backpack every day. He's not in a wheelchair, and he should already be in one. That is the importance of getting these boys treated early. I did hear that this is a 100% fatal disease, and it is, but it doesn't need to be fatal at 13. We're talking 20s and 30s now with proper care. I've heard about doing this a different way and getting it approved. Look, we already have the care. We have MDA clinic here at Showa. There's already a path to get treatment. We have gene therapy. We have exon skipping treatments. We have multiple other treatments that are available at birth. So there's really no reason to have a family like mine wait till he's 5, 6 years old and quite possibly be in a wheelchair by 6 because they weren't treated already. I think I'm going to close there. That's just my story, if you have any questions. But let's just save other families from having to go through all this when we could just a simple prick and we can know and we can start treatment and we can have a child instead of dying at 13, lived until their 30s, if not longer. Thank you.
All right. Thank you for sharing your story. Appreciate that. I said I was going to, I was thinking about it, but I'll be happy to entertain a motion.
Out of sake of time, since I yielded to let this go first, I'd like to make a motion to pass.
All right. Do I have a second?
Second.
All right. Any further discussion? I'll go with my fellow guy who seconded.
Number 5, Mr. Chairman. Yeah, I don't hear anything that indicates this wouldn't be approved moving forward. I think there's a whole battery of tests that are taken. This isn't a separate sample that's got to be taken. It's the same blood that's taken for other samples. It's just another it's another evaluation that's taken. And I think about this, and you can't put a price tag on life. If we are to ask ourselves the cost question, $8 per kid, I mean, it's essentially for every positive diagnosis it's $28,000 diagnosis. That's not a large price to pay writ large compared to, if you take 3,500.
I got you.
Yeah.
All right. Senator Chairman Cowser. All right. Gotcha.
Thank you, Mr. Chairman. I'm hung up on two things, and obviously your heartstrings are yanked out of your heart to hear of children with these type of things, but I worry when we circumvent our own law that is leaving this to the experts and they have not yet determined at the federal level or the state that this is an illness that belongs on this list. And the statute says that you test for these things for the prevention of the illnesses or treatment, and I'm not hearing that there's a cure. I don't know that testing prevents it, and I'm sitting here wondering, how in the world can anybody pay $2 million for this treatment? I mean, it's just heartbreaking to know that if you know that's just delaying, the onset of the symptoms. So I'm just struggling trying to do that. I don't want to slow you down. I don't know that I can have those answered today, but that's just what's troubling me.
Any further discussion? You have a question? Discussion?
Yes, Mr. Chairman. So it looks like none of these other conditions are listed that we're currently screening for now with the heel prick test for the newborn, which I think takes place in the hospital before the baby goes home. None of the rest of these are in the code. So it looks to me like is that correct? I mean,
Senator Robertson, you want to?
I think the code you're referencing to is the policy that was given by the department. Is that what you're referencing to? Right, and I want to point out, neither was the other one, the one that Senator Brass was discussing earlier. It was also not mentioned in there. The procedure's there, and briefly, when any of us that have ever been involved in drug testing, any of this other kind of stuff, when the department was up here talking, they talked about reagents. Reagents is the chemical that you test the test against to determine if the condition is there. There are different reagents for different types of conditions that are developed through labs. And so, talking about the build out and all this other kind of stuff, all we're trying to do here is, and you also heard the department say that they've been looking at this for a year, and then and it's amazing how when this bill drops, now we're getting ready for a vote, even though they only meet twice a year, April and October. And then it has to go to Emory, has to go to these other places, so we add another 12 months onto that. So it's 2 years that we're running into this. And so, again, while I appreciate what the department's doing, my challenge, Chairman, is that if this is the policy, then once this legislation passes, which I hope it does, I think it's time that we reevaluate the policy, because it doesn't list individuals. Now, I'm going to mispronounce it. It was the one that Dr. Burke moved forward with the K-crab or
It's crab.
yeah, crab.
Right.
That one showed that the process could work the way we're trying to work it now. It absolutely did. And there's only been one of those cases, but that's an important case to whoever's family it impacted. We're talking about at least 35 children a year here in Georgia. And Chairman Calzert is spot on. $2 million, I couldn't imagine if I had to spend $2 million. But you know what I could have? Quality of life with my daughter for as long as I could, because I couldn't afford $2 million.
Any further questions? No further questions, so we have been, motion do pass. It has been seconded. All those in favor, let's say aye. Aye. All those opposed, like sign. No. Okay. Looks like we have 2 noes. Is that accurate? Okay. And so, bill moves forward. Thank you very much. All right, so I have been I've been corrected in that there is nobody in this room afterwards, so we can go over it a little bit. And Chairman Brass, the floor is yours, wherever you want to be. You're correct. Nobody in, but anybody who needs to leave for a committee, you should go there. Okay. How many of you have a committee at 3?
Well, we share her.
Okay, we can. Jocelyn can go with you.
Yes, it came from.
No, we're we're going to be here, and you're in Arizona, and I made that. So if you need to leave, we will. All right, floor is yours.
Mr. Chairman, I have Naomi Lopez here. She's a senior fellow at the Goldwater Institute and is the architect of this legislation that has passed in Arizona, Louisiana, Maryland, Mississippi, and Nevada, and we are hoping that Georgia will be next. The purpose of the bill is to help children with rare diseases, cancer patients, and other vulnerable patients in Georgia. It does this by giving Georgia patients access to potentially life-saving treatments after they have tried all other FDA-approved options. The FDA approval process is based on an industrialized model that is meant for wide-scale manufacture of drugs and treatments. Thus, it applies to treatments that are for large populations. In turn, the process costs tens of millions of dollars and takes years. So it's not cost-effective for some of these rare diseases and rare treatments to go through that process, especially one that might only help one cancer patient or maybe 1,000 kids with a rare disease. Thus, treatments that might help these patients are sitting on the shelf even as they are available in Europe and other states. All treatments offered under this legislation are provided by healthcare professionals who want the best for their patients. The patients must have a recommendation from their doctor and provide written, informed consent. Treatment must be provided in a facility that has received official federal-wide assurance for protection of human subjects, which is the FWA, and it will follow all ethical policies for the protection of patients. We have many such FWA-approved facilities in this state. And this bill does this by creating a legal safe harbor and other protections that make it possible for healthcare professionals and hospitals to provide cutting-edge care, often based on the individualized condition and DNA of the patient. With that, I would love for Ms. Lopez to chime in and catch anything I might have missed, which is probably a lot.
Thank you. If you don't mind just introducing yourself and let us know about you, and then about the bill, please.
Chair Watson, members of the Senate Health and Human Services Committee. My name is Naomi Lopez, and I'm a senior fellow in healthcare policy at the Goldwater Institute, which is based in Phoenix. Thank you for allowing me to offer my public comments regarding SB 72, Hope for Georgia Patients Act, as you consider the important issue to protect the right to try to save one's own life without having to first beg the federal government for permission to do so. Imagine that there's a new treatment for a rare disease. It's custom made for you. It's based on your own genetic profile. It offers you hope, but you can't access it, even though your doctor says it could save your life. The reason? Federal regulations are ancient by today's standards, and they're not designed to allow these new genetic treatments. Georgia has an important opportunity to help lead the nation in solving this problem and save lives by championing the Hope for Georgia Patients Act. The federal barriers to life-saving treatment are not hypothetical. Georgia lawmakers have already been a leader in putting patients first and cutting through the medical red tape. Under the original Right to Try Act, which Georgia passed 9 years ago in 2016, patients gained the right to seek treatments that are safe enough to be used in clinical trials, but remain under clinical evaluation for final FDA approval. The federal Right to Try Act was later signed into law in 2018 and is now the law of the land. We know that Right to Try works, and we've seen some great examples. There's an aggressive form of cancer called glioblastoma. It has a 5-year survival rate of only 5%. Too often, patients are left with no promising treatments. Thanks to the liability reforms and reduced red tape that is part of the Right to Try law, some patients who are ineligible for clinical trials can now access an immunotherapy treatment that is in clinical trial through the Right to Try. Instead of being sent home to put their affairs in order, these Right to Try patients have a median survival rate of 20 months of life. That's up from fewer than 7. The trouble is, this law needs to be upgraded and modernized to account for the rapid developments in medicine, such as gene therapy, which aren't covered under the original law in most cases. That's where the Hope for Georgia Patient Act comes in. The new law does not change in any way the successful original Right to Try law. It does create a new, safe, and physician-directed pathway for those patients with rare and ultra-rare diseases who don't have treatment options in clinical trials or who need an individualized treatment approach that's made specifically for them. Many of the medical innovations being pioneered today have made it possible to take an individual's genetic information and create treatment for that individual person. But the current clinical trial evaluation system, which was created more than a half century ago, is based on treatments for large populations, not necessarily individual patients. Individualized treatments are being pioneered all over the world, but too often U.S. patients, such as little Kira Riley of Arizona and her family, had to travel overseas in the height of the pandemic for a potentially life-saving treatment, or they are going to succumb to their cruel diseases. But it doesn't have to be this way. Georgia can continue to lead on the important goal of getting the right treatment to the right patient at the right time. Removing the government red tape that stands in the way of a doctor's treatment options does not require additional taxpayer investment, and it can be achieved in a manner that ensures patient safety and informed consent. Georgia lawmakers have the authority, as well as the legislative vehicle, to unleash the potential of today's medical innovations to further benefit Georgia patients. Thank you for your consideration of this important reform, and I'd be happy to take any questions.
Mr. Chairman, I'll add two real quick. We submitted a committee sub on this, and I just kind of wanted to cover that real quick. So what we're doing in this legislation, we're saying that the department is prohibited from taking any kind of adverse actions against healthcare providers through Medicare or through their Medicare certification. And the original version just said department, and in our current law, when you say department, it would have fallen under DPH. So we have come back and clarified that it is DCH. That's the purpose of the sub.
Thanks. Thank you. Clarification of substitute. And we have two people that wanted to testify. Got a question here. Chairman Setzler on 5.
Thank you, Mr. Chairman. Thanks for being here. I saw some references to it. I'm really asking the question because there's those in the public who are watching that maybe haven't seen the sub. And I appreciate your work on this. Going to express, from a policy perspective, I oppose using embryonic stem cells, to do any research. Isn't there a section of this bill that says that this does not include the use of embryonic stem cells in the research?
Do you know? Yeah, go for it.
Chairman Watson, Senator Seltzer, thank you for your question. Nothing in this bill changes current Georgia law. If Georgia law restricts in any way embryonic cell research, then this law does not change that. So this law is in alignment with state law and does nothing to alter what's already on the books.
No, I think this. I'm not saying it changed the law. I think it's a clarification that in the definition of this does not include that or using. Again, hate to have to say it, aborted fetal tissue to use research. I wanted to say that because I appreciate the author attempting to put that in here. I think it's here. I just want to make sure for the public that as we perhaps move this forward, it's very clear in this bill.
Yeah, well, I think you're referring to research. We're talking about actual treatment here, and so
Okay.
I don't.
Well, I mean, if you look on lines 71 in that section, starting line 67, that's what you're talking about.
Yes.
That individualized investigational treatment, and then if you drop down,
It's provided such substances are
Oh,
not
yeah.
obtained from an abortion, such
Yes.
term does not include any drug, biological product, or device derived from human primary or secondary embryonic stem cells or cell lines.
There you go.
I think
So
that's
just-
got it, right?
It's
And
there.
that's what you're referring to.
I just want to make sure that people
Everybody's
are
clear.
that I'm understanding it and the public sees that. Thanks.
Any
And the
other
author's
questions? Any other questions from the committee? Mark Parnell from Georgia Faith and Freedom.
Hey, Matt Parnell, Georgia Faith and Freedom Coalition. Just wanted to offer our support for this legislation. We're committed to protecting life and ensuring individual freedom, and this bill meets both those marks. And I have it on pretty good authority that the Rules Chairman would be in favor of seeing this advance. So thank you all so much and urge your favorable consideration.
Thank you, appreciate that. And
True story.
Rich D. Augustinus. I'm sure I didn't say that correctly.
Pretty darn close, though. Thank you. Appreciate that. Senator Watson and Senators, thank you for the opportunity to testify in support of SB 72, the Hope for Georgia Patients Act. And thank you, Senator Brass, for sponsoring this important bill. My name is Rich DeAugustinus. I live in Chamblee, Georgia, and I've been a resident of our great state since 1981. Georgia is my home. I grew up in Cobb County, and after graduating from Georgia Tech, I spent my career at Coca-Cola, retiring 4 years ago. I am very committed to our state and the welfare of its residents. I'm a former chair of the board for Atlanta Ronald McDonald House Charities and a veteran of many other local and national nonprofit boards. The work that RMHC does is a labor of love for me. I also have a particular interest in rare diseases. I am the current vice chair of the Myositis Association and previously served on the board of the Mesothelioma Foundation. I am here today to speak on behalf of my father, Augie, who is living with the rare disease, and my late wife, Tara, who died of a very rare disease. My father, Augie, was diagnosed with inclusion body myositis in 2008. IBM, as it's called, is a rare neurodegenerative disease that slowly wastes away all of the muscles in the body. My dad is 17 years into IBM, and life for him now is in a wheelchair full-time. He can't do much for himself without help. In 2014, though, he participated in a clinical trial of a gene therapy that promised to rebuild muscle tissue in his legs. It was a phase 1 trial, which, as you know, is focused on safety, not efficacy. Miraculously, it was successful and built muscle in my father's legs. He was actually able to walk for a few more years. Unfortunately, the researchers could not find financial support for a phase 2 trial, and my father couldn't continue to benefit from this gene therapy. Had this legislation been law at the time, it would have cleared a path for my dad to continue utilizing this effective treatment, not only in his legs, but his arms, his chest, his neck muscles, etc. These are muscles that help you breathe and help you swallow. It would have likely delayed the further breakdown of his muscles and extended quality of life for him. This legislation also could have helped my late wife, Tara. She was diagnosed with mesothelioma in early 2016. Meso is a very rare cancer of the lining of the lung caused by exposure to asbestos. She fought valiantly for 15 months, but passed in 2017 at the age of 47, leaving behind me and our 15-year-old daughter. If you don't know about meso is considered one of the deadliest cancers in the world. Generally, if you're diagnosed with meso, it's a death sentence. It's not a question of if you're going to die, it's a question of how fast. Despite that, in recent years, there are a growing range of experimental treatments showing promise with mesothelioma. Treatments like CAR T-cell therapy and immunotherapy. Broader access to these treatments and others might just turn mesothelioma into a chronic disease that can be managed rather than a very painful death sentence. Simply put, this legislation would have given Tara a chance, and just as importantly, given her a chance to try some of these experimental treatments right here at home. As it was, I wasn't planning on saying this, in the last 6 months of her life, we had to take her to New York City to Memorial Sloan Kettering a half a dozen times for experimental treatments that she didn't have access to here. That can't be the future. Senators, there are likely between 300,000 and 500,000 people in our great state struggling with rare diseases, very likely in every single one of your districts. They need new options to improve their quality of life and to extend their lives. Simply put, they need hope. There are treatments out there that these Georgians can't access, effective treatments that are available in other countries or that could be in clinical trials here in the U.S. While this bill will not address every single situation, it will open the door to a lot more opportunities for access to care. It will open the door to hope for many. Please support this bill and let's make it law during this legislative session. Do it for Augie, and please do it for Tara and countless others in your districts that very much need it. Thank you very much.
Thank you. Appreciate your thoughts and sharing that with us. So before we lose quorum, as we have 7 as our quorum, actually you count 2, so that's 8. So 7's a quorum. You're good to go. Thank you. Any further questions or any questions at all? Be happy to entertain a motion. Move to pass from Chairman Cowsert. We have a second. Any further discussion? No further discussion. All those in favor say aye. Aye. All those opposed, like sign. Passes unanimously. Thank you so much. So next meeting is Wednesday at 4. All righty. And I said we were going over. We actually, it did take 1 hour, didn't it, for both bills. We just got a little bit of a late start there to public safety. Thank you.